Yeah, Suchit, I would just request you to keep your talk within next 13 minutes because we
Sure.
have another
So
session.
we're going to be talking on the scope of conduction system pacing, and he's going to be adding data to what Dr. Rana Datta added.
Okay, can you share this thing? I was not able to share. Then they have the PPT. Hello?
So have you shared your presentation with them?
Yeah, they have it. Because otherwise, no, I cannot transfer this here. With phone, I cannot show it.
Dr. PC, any more sort of things that you would want to talk about?
I think recently some debate is there. If it is suppose even MRI not showing any scar, and what is the role of genomic analysis before the final decision of CRTP or CRTD? Any role of genomic analysis regarding some inherent channelopathies that can be a contributing factor and cause of sudden death?
So I think the genomic workup really comes in patients when they have symptoms. So I don't think so. I mean, there are two ways of looking at it. One is that when you're looking at a family of a patient who has a sudden cardiac death, and you want to find out whether the other members are going to be affected and if they are carrying the same high risk genetic factor, then that is where we would probably want to do a genetic study. But in a patient who has ischemic heart disease, probably I don't think so.
No.
We will probably
not in ischemic heart disease, non-ischemic cardiomyopathy, particularly two extremes of age. Suppose onset is at the before 20 or in the teenage, or it is more after 55 or 60.
Can I interrupt?
Yes.
Yeah, the presentation of Suchit is ready. So I think.
Please go ahead. Yeah, Suchit, you can go ahead.
Start his presentation.
Please share. Okay, I think it is visible. So let us go ahead with the presentation. So next slide. Okay, so I think it has already discussed here that the patient is a 45-year-old male with a recurrent hospital admission for heart failure. It's an ischemic cardiomyopathy with an EF of 28% and old anterior MI, probable non-viable LAT CTO needs to confirm also, and sinus rhythm, ECG, LVEV, and on goal-directed medical therapy. So this is the gist of the case. Next slide. So the questions here is that why is it a candidate for BIB or a CSP or both, and what does the data say here, and what does the guidelines recommend? Next slide. So this is the trial. I'll go the different studies which has looked at this. This study was in 2018 published. It is his synchronization versus biventricular pacing in patient with heart failure and left bundle branch block by Arnold AD. Next slide. So what did this study? In this study, if you can see, there are 38% of the patient had a history of previous MI. Others were probably non-ischemic cardiomyopathy. And in these patients, it was shown that his bundle pacing reduced the QRS duration significantly, reduced the LV activation time significantly, LV desynchrony index, and also there was an hemodynamic improvement. Next slide. So this is very important to understand how a CSP differs from a BIB in LV activation and also RV activation. So upper panel shows RV activation, the lower panel shows LV activation. And in this study, they have looked at ECG West. By that, they see the activation pattern of the heart, and they have seen that if you have an LVEV, the blue area is the latest activated area in the lateral wall. But if you have a His bundle pacing, there is complete resynchronization with no blue area. But if you have biventricular pacing, it is midway between the two, that there is still a late area in the lateral wall. Next slide. So this gave rise to one or two studies. One is the His-Sync study and his alternate study. The His-Sync study, around 41 patients that were NYHA class 2 to 4, and they were assigned to his CRT versus a BIV CRT. And this showed a significant reduction in the QRS duration, but the change of EF was not significant in this trial. Next slide. So this is the His alternative study. In this study, they have again looked at His bundle CRT versus BIV CRT, and 50 patients were randomized into His CRT and BIV CRT, and this study showed that His CRT provided significant improvement of cardiac function compared to BIV CRT. So here the LVEF improvement was also there in the intention to treat analysis. The NYHA functional class also improved, and QRS also improved significantly. Next slide. So coming to left bundle pacing, because his bundle pacing, the problem is that there is an increase of threshold, it is unstable, there is more chance of atrial capture, and also ICD sensing, if it is a CRTD, ICD sensing cannot be there very well from the his lead. All these problems led to understanding of left bundle branch pacing. Here we place the lead into the proximal left bundle branch, and then we pace to have a resynchronization. So these are one or two proof of concept analysis. Here it showed in 2020, the study showed that left bundle branch pacing compared to this thing causes an improvement of the EF in a patient with an LVEF of less than 50%. Next slide. This study by Vijayaraman et al. It showed that left bundle area pacing for cardiac synchronization therapy, there was significant improvement of the ejection fraction, and also there is a significant decrease of the QRS duration, and also this was in all groups of CRT, LVEV and non-LVEV group also. Next slide. So this was a LV desync trial. This was by Dr. Zhao et al. We showed, but it was actually not very important for our patient because it's a non-ischemic cardiomyopathy patient. And here it showed in intention to treat analysis that there was significant change of LVEF in the left bundle branch pacing group compared to BIV pacing group. Next slide. So this is a recent study in 2022 published. It was the clinical outcomes of conduction system pacing compared to biventricular pacing in patients requiring cardiac resynchronization therapy. This was again from Dr. Vijayaraman's group. Next, but it was 2 centers, I think. Next slide. So it included consecutive patients LVF less than 35% and class 1 and 2 indication for CRT who underwent BIV pacing or CSP at 2 centers. Primary outcome was composite endpoint of time to death or heart failure hospitalization, and secondary outcome was subgroup analysis in left bundle branch block group as well as individual endpoints of death and heart failure hospitalization. Next slide. So if you see here the baseline characteristics of the study, they have divided into all patients and then the LVEV group. You can see that there was a very good mix of NICM and ICM, unlike others which mostly had an ICM. Most of the patients were on goal-directed medical therapy, but if you see the ARNI use was only around 20 to 21%. And most patients had an LVEV. Next slide. So the procedural duration, if you can see, the CSP had a higher procedural duration significantly, but if you see the fluoroscopy duration, both were comparable. And threshold and all these things were comparable, and the pace QRS duration was significantly lower in the CSP group than in the biventricular pacing group. Next slide. So the primary outcome, if you see freedom from death or heart failure hospitalization, it was significantly reduced in the biventricular pacing group, significantly reduced in the CSP group compared to the biventricular pacing group. And freedom from death or heart failure hospitalization was significantly more in the CSP group, even in the LVEV analysis. So there was significant improvement in the CSP compared to biventricular pacing. Next slide. So this was a secondary outcome. It looked at freedom from heart failure hospitalization. That was also better in CSP compared to biventricular pacing. But freedom from death, it was not significantly different between the two groups. Next slide. Am I audible?
Yes, you are audible.
I don't know, somebody is calling me, I don't know, from your side. That's why I'm listening. Anyway. So if you see the outcomes of these studies, we can see that in all patients and also in LVEV group, there was significant decrease in the QRS duration in the CSP compared to biventricular pacing, and LV ejection fraction was also improved in the all patients analysis versus also LVEV analysis. Next slide. I'm not going into detail because of paucity of time. Next slide. So the study concluded that CSP was associated with a significant reduction in the primary composite outcome of all-cause mortality or heart failure hospitalization compared to biventricular pacing undergoing cardiac resynchronization therapy, and it was significantly reducing the heart failure hospitalization, which is very important in these sort of patients and also in our patient. Next slide. So what are the current challenges? One is to predict LVEV correction, determine successful LVEV capture, and also which should be done, biventricular CRT versus hot CRT versus LOT CRT. Next slide. So it is to the best indication of CSP in heart failure is still a non-ischemic cardiomyopathy because they have base of His-Purkinje disease distally, and LVV pattern should be there with a QRS duration of more than 130, and there should be not be any scar in the septum because otherwise screwing the lead will be problem. Next slide. So I am not going into detail. Next slide. So optimization of CSP in heart failure. So if LV left bundle capture is succeeded, then only left bundle branch pacing with LV interval optimization is encouraged. But if you don't have a good left bundle capture and decrease of QRS, then you can add a LV lead. That is called as a hot CRT or a LOT CRT. Again, his bundle pacing is not being done these days much because of the concern I have already said. So LOT CRT is the choice in those cases where it is not optimized by left bundle pacing alone. Next slide. So this is hot CRT. It has shown a significant improvement of cardiac function from 24% to 38% in this trial by Dr. Vijayaraman et al. Next slide. The LOT CRT, there is a definite connection is required. You require often a DF1 lead where you can put the sensing lead there. And so it was successful in 81% of the patient. It resulted in significant narrowing of QRS complexes and EF increase. Next slide. So coming to the guidelines, this is the recent guideline which has been published this year, May. So on cardiac physiologic pacing for avoidance and mitigation of heart failure. Next slide. So in this guideline, they have in the LBV left bundle branch block pattern, this thing, the indications that they have put is that if effective CRT cannot be achieved, in those cases only His bundle pacing with LBV correction or left bundle area pacing is required as per these guidelines. Next slide. So this is the guideline. I am not going into detail because it's same thing only what I have told. Next slide. So in a patient with a QRS duration between 120 to 149 where our patient falls, in patient with select characteristic, example female sex who have less than EF of 35% sinus rhythm and NYHA class 2 to 4 symptoms on GDMT, CRT with biventricular pacing is recommended to reduce mortality and heart failure events to improve LVEF. So again here His bundle pacing is only when you cannot do by CRT. Next slide. So coming to this patient, is a ischemic cardiomyopathy, male, LVEV QRS of 140, recurrent hospitalizations on GDMT. Next slide. So in typical LVEV, data from studies show that CSP has better reduction of QRS, improvement of EF, prevent recurrent hospitalization compared to BIV pacing, but we need more RCT to substantiate this data. The Vijayaraman's group trial that was presented last in 2022 was not a typical, was not a randomized control trial. As per guidelines, at QRS 140 and male patients, BIV is class 2A indication and CSP in cases where BIV cannot be done anatomically or functionally. In this patient with significant scar and ischemic cardiomyopathy, LOT CRT may be a better choice as His-Purkinje disease is likely to be more distal in these cases. Thank you.
For that wonderful talk. I think for want of time, I think the organizer asked us to stop to close this session.